So thank you all for attending our webinar titled The ABCs of ADCs, What Pulmonologists Need to Know About Antibody-Drug Conjugates. This webinar is sponsored by the Thoracic Oncology Assembly Early Career Working Group, which my co-presenter is Dr. Kathleen Capaccione, Maida Hafiz, and I are a part of. So antibody-drug conjugates are a combination of a monoclonal antibody covalently attached to a cytotoxic drug via a chemical linker. There are three distinct parts of the antibody-drug conjugate: the antibody, which binds to antigens on tumor cells, the linker, which prevents premature release of the cytotoxic agent before internalization, and the payload, which is the cytotoxic agent. Though the goal of the antibody-drug conjugate would be to selectively target tumor cells, we think toxicity arises from binding to physiologic non-cancerous cells or from premature release of the payload into systemic circulation before they're able to get inside tumor cells. This figure shows the antibody-drug conjugate binding to a cancer cell, internalization, and the lysosome degrades the antibody portion, which allows the payload or the cytotoxic agent to destroy the cancer cell. The payload can also travel to nearby cancer cells, something called the bystander effect. And as antibody-drug conjugates are being increasingly utilized for various hematologic cancers, the top row are the FDA-approved agents for those, and solid tumor malignancies, which is the bottom row, with many more currently in various stages of clinical trials. And as pulmonologists, I think we'll be seeing more of these patients on these medications, both concurrently or in sequence with other cancer treatment options like immune checkpoint inhibitors. And we'll have to be familiar with the pulmonary complications of each of these various agents. Trastuzumab deruxtecan is one of the first and most commonly utilized antibody-drug conjugates approved for use in breast cancer patients. The pneumonitis risk in early studies, which consist mostly of breast cancer patients, showed an incidence around 15%, which is higher than the pneumonitis risk for other cancer treatments, which includes immune checkpoint inhibitors. In the same study, 22% of the patients who developed pneumonitis required oxygen supplementation, and around 2% died directly from pulmonary complications. In the early studies, the median onset of pneumonitis was around 5.4 months, and most of the patients who developed pneumonitis did so within the first 12 months of treatment initiation. And this is a more updated meta-analysis from 2024, and this includes all antibody-drug conjugates and not just trastuzumab deruxtecan. And when they're all pulled together, incidence of pneumonitis was around 5.8%. In grade 3 events, or patients who developed pneumonitis and required oxygen supplementation or hospitalization, was around 1%. There are several emerging roles for antibody-drug conjugates for the treatment of lung cancer, and I summarize the agents we have in the table below. From prior studies on pneumonitis with other non-antibody-drug conjugate cancer treatment modalities, like immune checkpoint inhibitors, we know lung cancer patients may be at higher risk for pneumonitis compared to patients from other types of cancers. So this may be a population to pay special attention to as antibody-drug conjugates are used more in the thoracic oncology space. I'm going to turn over to Kathy for more radiographic patterns.
So thank you so much for that really excellent introduction on how these drugs work. So as radiologists, we're very interested in the patterns of lung disease, especially as more and more of these immunomodulatory agents are becoming available, and many of those agents have a lot of different immune-related adverse events. So a lot of the work that has been done on this has been done on immune checkpoint inhibitor side effects, because that was one of the first that came to the clinical use. So it's important for pulmonologists and oncologists, as well as radiologists, to be acutely aware of this, because pneumonitis is a big risk. It's especially a risk for those patients who have lung cancer, both because many of them already had coexisting conditions like COPD or interstitial lung disease. And now with the lung cancer diagnosis, they have even less functional lungs. So it's extremely important to be, acutely aware of the potential for pneumonitis in these patients, and then to really understand what to do when their disease, when you see their disease radiographically, or when they present to the clinic with some of the side effects from their pneumonitis. So this, as I said, was initially investigated in immune checkpoint inhibitor immunotherapy. And here I have two of the I have images from two of the papers that began the characterization. And what they were able to demonstrate with these studies was that the immune checkpoint inhibitor pneumonitis manifested as patterns of interstitial lung disease closely mirroring those that had been seen previously. So organizing pneumonia, NSIP, UIP, DAD, HP, those were what people were seeing. Now, moving forward specifically to ADC pneumonitis, less has been published on this because it's such a relatively new therapy, but there has been a study on trastuzumab deruxtecan, and what they found was very similar to what has been seen in the ICI immunotherapy studies. So they focused on two things. One was the grade of the pneumonitis, and the other was the pattern. So the grade is very important. This is based on the CTCAE, which is the criteria, the common terminology for adverse events. And the reason that that's important is because depending on the grade that you see when in the patient's either clinical or radiographic presentation, it dictates what the management for the patient will be. So grade 1 and 2, they're the lowest grade, so the least severe. And in those patients, interventions like reducing the dose of the drug or giving steroids may be appropriate, and they could potentially be able to restart an agent in the future. Grade 5 and grade 4 are very serious. In grade 5, they may not be able to recover from grade 4 or 5, and in fact, it may result in the patient's mortality in patients with that severity of disease. Now, in terms of the imaging pattern, they also looked at that in this study, and what they found was that the preponderance of patients had disease in an organizing pneumonia pattern. Next was a hypersensitivity pneumonitis, and then DAD and NSIP. So it's a little bit different than the checkpoint inhibitor immunotherapy because NSIP was, I think, more prevalent in those populations, and I don't think they saw quite as much diffuse alveolar damage, although it varies from study to study. In terms of drilling down on what the patterns look like in case you're not familiar with them, so diffuse alveolar damage, we see just this like diffuse ground glass throughout the bilateral lungs. You can see it's very severe compared to the patient's normal lungs previously. Organizing pneumonia, we have rounded opacities, which are irregular and in different places in the lungs. Hypersensitivity pneumonitis is these peribronchovascular opacities that you can see have developed in this patient. And then finally, NSIP, we can see that they're bilateral lower lobe predominant subpleural opacities, and that there is subpleural sparing, which is really the hallmark of an NSIP pattern. So just finishing out on this one study, what happened to these patients? What were their outcomes? So in about 40% of the patients, they resolved and they didn't have any sequelae from the pneumonitis from their ADC. Unfortunately, about 9%, 8.5% passed away from the pneumonitis. And then in the rest of the cases, which was about 50%, there was some type of long-term sequelae, or they were in the process of recovering at the end of the study. So now I'm going to turn it over to Maida to discuss, what you should do when you have a patient who you suspect of ADC pneumonitis.
The management of ADC pneumonitis is based mostly on recommendations from key opinion leaders. And whenever you suspect an ILD related to an ADC, which your suspicion would be based on any new radiographic changes, which are potentially consistent with ILD, or they develop new pulmonary symptoms or worsening of their existing pulmonary symptoms, such as dyspnea, cough, or fever, then you would try to confirm it to as much certainty as you can, given that this is a diagnosis of exclusion. So some of the investigations that you would do include a high-res CAT scan, blood work as indicated, trying to evaluate for new oxygen requirement, and bronchoscopy and BAL if the diagnosis is if you're not sure about the diagnosis and if you would like to, for example, rule out infection. But this may not always be clinically feasible. And then with regards to management, here something that is different from ICI pneumonitis is that even for grade 1 pneumonitis, the recommendation is to interrupt therapy. And for 2 to 4, the recommendation is to permanently discontinue treatment. Next slide. With regards to the actual treatment for the pneumonitis after your suspicion, after you're ruled out some of the other potential diagnoses, is to try and treat with steroids. So after you're holding therapy for grade 1 pneumonitis, you would treat it with systemic corticosteroids, prednisone in the outpatient at a dose of 0.5 milligrams per kilogram per day until there is improvement, and followed by gradual taper over 4 weeks. You would also follow them with imaging. The recommendation is every 1 to 2 weeks, but this can be a lot in actual clinical practice, and I think most people do it from every 2 to 4 weeks. And then if there is worsening of symptoms, or if there is not an improvement in the symptoms, then you would follow the guidelines for grade 2 pneumonitis. For grade 2 pneumonitis and above, you would discontinue therapy, and you would start again corticosteroid treatment with prednisone 1 milligram per kilogram per day or even more for 14 days or more, or until there is complete resolution of clinical and CT chest findings. And then you would gradually taper it over more than 4 weeks. Again, if the patient does not improve or if there is worsening in their clinical symptoms over the initial week or so, then the recommendation is to increase the dose of the corticosteroids to 2 milligrams per kilogram per day of prednisone or equivalent. And if they are in the hospital, you would do IV solimedrol. And again, you would consider other potential diagnoses. For grade 3 and 4, these are patients who will frequently require hospitalizations, and the recommendation is to promptly start empiric high-dose solimedrol IV, which would be 500 to a gram of solimedrol for 3 days. So this is pulse steroids, followed by high-dose steroids of 1 milligram per kilogram per day, prednisone or equivalent, again for 2 weeks, or until there is resolution of clinical and CT chest findings. Over 4 weeks or more. You're going to be re-imaging, consider other potential. So we do not have a definite steroid and resistant pneumonitis in ADC pneumonitis. In pneumonitis, the definitions for steroid refractory and resistant are patients with no improvement or worsening of pneumonitis with initial treatment with systemic steroids were defined as steroid refractory, whereas patients who initially responded to steroids but subsequently developed recurrent pneumonitis in the context of steroid tapering in the absence of ICI rechallenge were called steroid resistant. Next slide. Now, when the patient does not respond to steroids, which for ICI pneumonitis, 80% of the patients do respond in general, and 20% do not, and fall in the category of steroid resistant or refractory, then the options, there is not very good guidance for where do we go from there on, and usually management from there on is dependent on individual comfort level and what the practice of the institution is. But some of the other immunosuppressants that are used include infliximab, Cellcept, IVIG, tocilizumab, and we do not have good data in the space of ADC pneumonitis. However, there are a few studies, mostly retrospective, for ICI pneumonitis. For example, this one study, which compared the use of infliximab or MMF for ICI pneumonitis, they found that for patients who were steroid refractory or resistant, and they were given either of these agents, the durable response was only 38%. Whereas another study, which looked at the use of IVIG, infliximab, or a combination of these, 75% still died of steroid refractory ICI pneumonitis or infectious complications. So I just brought this data here because we do not have data yet, no clear data for ADC pneumonitis, and I just wanted to show that we do not have good guidance even for ICI pneumonitis and do not have good options beyond steroids.
So since we don't have good data or guidance on a lot of these things, and the ADCs are a pretty new cancer treatment overall, we wanted to bring in a couple of experts to discuss how they approach and treat and diagnose ADC pneumonitis and kind of give us insight on some of the edges of practice. Dr. Gatti-Mays is an associate professor in internal medicine and the section chief of breast medical oncology at The Ohio State University. Dr. Jennifer Possick is a pulmonologist and associate professor at Yale University. She's the director of the Winchester Center for Lung Disease and an oncopulmonologist at the Center of Thoracic Cancers at the Smilow Cancer Hospital. And Dr. Jay Leb is an assistant professor of radiology at Columbia University. He's the director of cardiac imaging and the program director for Cardiothoracic Imaging Fellowship. So we just wanted to kick things off maybe with starting with Dr. Gatti-Mays. But as a breast oncologist or just an oncologist in general, what would you like us as pulmonologists and radiologists to know about antibody-drug conjugates and maybe what type of tumors are most commonly treated with ADCs these days?
Sure. So thank you so much for having me. I think this is really a very important topic to cover, especially as antibody-drug conjugates really become the mainstay of treatment in many cancer types. Just back in October of 2024, I think there were 13 different antibody-drug conjugates that have been approved to date. As we extend the use of antibody-drug conjugates into more cancer types, not only in solid tumors, but also in hematologic malignancies, I think obviously making sure that we are also aware of the toxicities that occur with these is really important. As an oncologist, I know I have been absolutely floored by the responses that we see with these antibody-drug conjugates. And so we see some very treatment-resistant cancers responding very well to the antibody-drug conjugates. So in oncology, I think there is a lot of excitement about trying to get these antibody-drug conjugates into patients. I think obviously with any type of novel treatment, as we increase the use in our oncology patients, we tend to see probably more incidents of severe toxicities like pneumonitis. One of the things I did want to point out about ADCs is while the mechanism is really unknown for the interstitial lung disease, we do think it's likely due to the payload. So currently with trastuzumab deruxtecan is the payload. There's also several other antibody-drug conjugates that are coming down the pipeline using the deruxtecan payload. One is datopotamab deruxtecan, which is being evaluated not only in lung cancers, but also in breast cancer. And then also paritumumab deruxtecan, which is also another antibody-drug conjugate for non-small cell lung cancer. So when thinking about these ADCs and the toxicity for pneumonitis, really focusing on the payload. And again, as an oncologist, I think you're probably going to see more and more patients being exposed to antibody-drug conjugates. So really important to have multi-D collaborations. And I know obviously working with Kevin, I quite appreciate the frequent communication, and that's very important.
And is there because we know about ADCs being used more now, but how often are they used with other cancer treatments, whether that's like chest radiation or immune checkpoint inhibitors, both in breast cancer and maybe other cancers as well?
Sure. So I think in the meta-analysis that was presented earlier in this presentation, there were several clinical trials that combined ADCs with other agents. Currently standard of care, there's no combination therapy, but I think there is a lot of interest of combining ADCs with immune checkpoint inhibitors. So obviously that potential, I think, for pneumonitis is probably going to be a little bit higher. But currently there's only single agents. I do think, with some of those clinical trials, though, that are using the combinations, there is some increase in activity. And so it would not be surprised if over the next few years we see some more combination therapy as well.
Okay. And then for both Dr. Possick and Dr. Gatti-Mays, how frequently do you guys encounter side effects clinically? I know we quoted some numbers, but they were kind of early meta-analysis and kind of grouped some agents together. Some are just on trastuzumab deruxtecan. And how does this compare to side effects you guys have seen from other cancer treatments?
Sure. And actually, Kevin, just to kind of I realized I didn't answer your question about radiation therapy. In terms of side effects, I do think that especially when using with radiation, especially from a pneumonitis perspective, I do think that we see probably a little bit more pneumonitis with the antibody drug conjugates when used in combination with radiation than when we see them just used as by themselves. I mean, they're a different, kind of treatment. I do not, as an immuno-oncologist, I would not consider these necessarily immunomodulatory or immunotherapy. These have a very different mechanism than other types of immune activating agents. And so, I think they're similar in the sense we can definitely see some pneumonitis, but it seems to be a different, pathway, different mechanism than what we see with immune checkpoint inhibitors.
And just to jump in and add, I think you had asked about like the frequency with which we're seeing it on the pulmonary side, Kevin. I think we're starting to see these cases much more frequently. I think as it's similar to the story with checkpoint inhibitors, that as we see them move into standard of care and being applied with more patients, you're just encountering more cases. The thing that I think we're finding too that is similar to the ICI story is that as people have become more familiar with the side effect profile and more comfortable with recognizing it, we're seeing a lot of low-grade pneumonitis recognition with these agents. And thankfully, a lot of the presentations are grade 1 and grade 2, and they tend to be very responsive. When you encounter fulminant pneumonitis cases, they're striking. They're often very difficult to treat, but they are more few and far between. Where this differs from managing and recognizing ICI pneumonitis, I think really is about the low-grade disease, particularly the grade 1 reactions, because the stakes are so high for making an appropriate attribution and for acting quickly. Because the disease response rates, as Dr. Gatti-Mays had indicated, are so promising in these diseases. Patients do so well on these drugs that making a determination that they're having a reaction and either suspending or potentially discontinuing their treatment is a big decision to make. So it's differing from ICI pneumonitis, where we have some comfort and some margin of error with being able to observe people while they continue on therapy, really can't do that with these agents. So you need to make a recognition early, you need to make a decision that you definitely think this is attributed to the drug, that you've definitely excluded other mimics, infection being the most common one, and that you've also made an effort to act on it early. As you discussed, there is a role for applying corticosteroid treatment to grade 1 pneumonitis events, which is really not something that we do with grade 1 ICI checkpoint reactions in the majority of cases, or with other drugs as well. We do a lot of drug holds and observation. But, part of why we tend to act earlier on these reactions for grade 1 is that there's a window for grade 1 to being able to restart it without a dose reduction if they resolve quickly. And so, do you afford someone a greater chance of being able to go on the same dose that they were on before by acting early and acting aggressively? I don't know that we really know that you impact their ultimate outcome that way, but that's part of the spirit of intervening quickly.
And have you noticed, since as like a pulmonologist, you kind of see a spectrum of cancers that are treated with this, any particular tumor type that's maybe higher risk, like lung cancer patients or bladder cancer, things of that nature?
I think, in my experience, the majority of patients that I'm encountering with this are breast cancer patients, because they are the largest population being treated. At our center, we are seeing patients with urothelial malignancy who have received ADC in combination with ICI, and those patients do appear to be at higher risk of developing pneumonitis. And then it's very hard to appropriately attribute it to one drug or the other, right? And so those cases are challenging, but I expect that as we see this introduced more to candidate patients with lung cancer, we're going to encounter that as a more challenging clinical scenario because those patients tend to have less pulmonary reserve, right? Like we talked about earlier in your talk, they tend to have pre-existing pulmonary comorbidities. The primary site of disease is in the lung, and their margin for tolerance of any reaction, even a low-grade reaction, is much smaller.
And to kind of build on that and bringing up what you had discussed about, like, because of how effective they are in controlling cancer, do you have an approach to, like, before starting treatment, pre-treatment risk factors that we should consider or think about before starting treatment with ADCs? Not necessarily saying not to start them at all, but any key populations you're keeping an eye on as someone is starting treatment.
Sure. So I think, definitely patients that have interstitial lung disease, I think that that's a very significant conversation we need to have with patients, and obviously having pulmonologists involved in that discussion, I think is really important. Most of the studies with these antibody-drug conjugates have excluded patients with interstitial lung disease. So I don't really think we know at this point if we can challenge those patients safely. But generally, anybody with pre-existing lung disease, in addition, so COPD. We do know patients, obviously, with lung cancer have a slightly higher risk of pneumonitis, as was pointed out in the slides. I think, one of the questions, obviously, that comes with that is that perhaps the cancer itself or the prior treatments, including radiation. Those patients with lower oxygen saturations at baseline, most of the studies use 95% as kind of the cutoff. Those patients with tobacco use, older patients, so over the age of 65, and those patients with decreased renal function, all of those are risk factors for pneumonitis. And so discussing with that patient, I do think with a lot of these antibody-drug conjugates in terms of the older age patient population, our geriatric patients tend to tolerate these ADCs actually much better than many chemotherapy regimens. And so, that sometimes is a hard group to not give this, this class of agents to, because of the fact from a general symptom perspective, they do much better, and quality of life, they do much better. But just being aware that obviously that's one of the risk factors as well for pneumonitis.
Yeah, I think it's really important to know where your patients start. And to remember that the patient is part of the multidisciplinary team too. And so really engaging them, knowing where their functional capacity is at the beginning of treatment, so that you can coach them to recognize what truly is a new symptom versus what is part of their pre-existing baseline. And then from a radiographic standpoint, I think the oncologists are really good about engaging us when they recognize something unusual on a baseline scan that is maybe evidence of subclinical pulmonary comorbidity that hasn't been explored before. And so characterizing that up front, it doesn't necessarily preclude going forward with therapy, but it's just important to know where you are, to know what someone's lung function reserve is like, to know what is the nature of the radiographic changes that you're already seeing pre-treatment, and then being able to judge more effectively as you move ahead whether something represents a significant clinical change in the context of receiving these meds or not. So all of that's really important.
And Dr. Lev, have you noticed anything like radiographically as you're reading these studies, at least pre-treatment, in patients that go on to develop pneumonitis, whether it's interstitial lung disease, interstitial changes, or emphysema, degree of emphysema, things of that nature?
Yeah, thank you so much for having me. Well, obviously, the patients who, like was mentioned before, those who have already pre-existing ILD are going to be more, or other lung diseases, such as COPD, or if they had radiation to the lung, as all have been mentioned before, definitely are more likely to have pneumonitis, or we're more on the lookout for it. some of the other, I specifically find with the radiation, it's interesting that, when there's been a radiation field, I find that those patients show their pneumonitis first in that radiation field. Now, sometimes it's hard to tell if it's just from the radiation itself or if it's actually either the immune checkpoint inhibitor or the ADC or any other of the other drugs that's actually driving it or it's actually making it worse. So maybe sometimes there's a combined pathophysiology to it. In general, I deal with a lot of patients with lung cancer, and also patients who have metastasis to the lungs, and many of the times we pick up these findings incidentally, just on the screening or the follow-up 3-month or 6-month follow-ups, and there's times where it looks like some of the classic patterns that Dr. Capaccione showed before in the slides. But many of the times we find these, non-specific, ground glass changes, and then we're a little bit stumped of what to do with them. Is it a little infection? Is it some developing brewing pneumonitis? And sometimes it's very hard, and that's where I think the multidisciplinary approach and the, good communication with the oncologists and sometimes the pulmonologist is very important. There was a Fleischner statement, the Fleischner Society guidelines, which is a consensus group that puts out a lot of things for chest radiology, and they came out with the guidelines in 2021. And one of the things they talk about is something called simple, which was not mentioned, something called simple pulmonary eosinophilia, which is trying to describe some of these ground glass changes that we see, which are non-specific, but sometimes could be migratory and sometimes could be transient. And then those are more associated, usually with those, asymptomatic or low symptomatic patients who may have some pneumonitis and usually, resolve over time. But in general, the patterns that Kathy mentioned for sure are something that we see. And I personally think that the ones that hit us, or ones that are the easiest for us to really appreciate is related to pneumonitis, is the organizing pneumonia pattern. In organizing pneumonia, you have these what's called peribronchial opacities, which cause stretching of the airway. You get what's called traction bronchiectasis, and those are the things that we're classically trained to look for pneumonitis. Some obviously diffuse alveolar damage, which is a diffuse process more associated with clinically ARDS, is obviously those patients who are striking, and those are going to be your most severe patients. But organizing pneumonia, for me personally, has been the thing that I've seen the most.
So just to follow up on that, thank you, Dr. Webb. That was really excellent. And this is not only open to you, but to all of our discussants, because I think it's something that touches each of our specialties in a different way. But how often should the imaging be obtained for these patients after their treatment, after ADC treatment? And should the interval be shorter in terms of, what the normal standard follow-ups are for patients, oncology patients? And if the interval should be shorter because of these, potential, I don't know if you call them ILAs, but these ground glass abnormalities that you're seeing, are there specific patients for which you think, we need to make that interval shorter?
So, I mean, as the radiologist, I maybe have a different approach than some of the clinicians, but in general, first of all, the TDXT trial, they were scanning for every 6 weeks to look for incidental or asymptomatic detection of pneumonitis. They readily admit in one of those consensus papers, they readily admit that insurance companies probably will not pay for a scan every 6 months if they're not on clinical every 6 weeks, if they're not on clinical trial. So in general, many of these patients, especially for the patients who are asymptomatic, are being scanned just with their regular cancer follow-up, either 3 to 6 months. Obviously, in a patient who then develops a pneumonitis, obviously you want to follow them very carefully. And I heard it was mentioned before that the recommendations are to follow them every 1 to 2 weeks. I'm sure that if you're giving heavy dose steroids and they're quite sick, probably that is the way to go. I want to sometimes from a radiological point of view, you know, we see a lag. So especially if the patient's symptomatic and then becomes asymptomatic, you know, sometimes the lung findings will still be present and may not be that much better, even though a patient's gotten much better symptomatically. So it's hard. It's a hard call to make. Obviously, you're trying to keep the patient on treatment, or you're trying to, you know, weather the storm. So the shorter term imaging, the better. At the same time, we may not see that big of a drastic differences sometimes. I know, you know, just not from the pneumonitis itself, but even from, you know, following, you know, malignancy in general, sometimes that short interval follow-up, you don't see that real big difference. You'd have to look it over a little bit more of a stretched out time to really see the changes. Sometimes the eye just doesn't pick it up. So.
And I would agree. I mean, I think you know, most insurances will not pay for, you know, routine kind of screening or, you know, even restaging scans every 6 weeks. I think, you know, if you do have somebody obviously that has a concerning finding, I think that that's reason to, you know, to follow up with a shorter interval CAT scan. But, you know, in my patients that I, you know, as a breast oncologist, I use a lot of trastuzumab deruxtecan, a lot of antibody-drug conjugates in general. And typically I tend to scan these patients about every 9 to 12 weeks. Unless they become symptomatic. If they become symptomatic, then I'll move it up, you know, and but other than that, though, I think the 9 to 12 weeks has been, you know, enough, especially if for some of these asymptomatic kind of detections of pneumonitis. If they're symptomatic, though, obviously scanning a little bit sooner.
Okay.
So again, following up on that question, I'm sorry, wait, go ahead.
Yeah, go ahead. Go ahead.
Okay, so sorry, I was muted. So for patients who go on to develop ADC-related pneumonitis, and this is a question for all of the discussants, for the ones who go on to develop pneumonitis, how often do you follow them clinically or with imaging and PFT?
So I can kick that off. So let's maybe talk about the patient who has grade 2 pneumonitis. So they've developed radiographic findings in association with symptoms, but they are not so sick that they've been hospitalized or developed an oxygen requirement. My personal practice is that I'm following them clinically relatively closely while I'm treating them with steroids. So at the beginning of that journey, you want to make sure that they're actually responding as expected. The majority of people will respond to steroids, right? But you want to ensure that that's the case, because like with ICI pneumonitis, if you need to escalate what you're doing and upgrade them, you need to make that decision pretty early on. So typically within days to a week at most, but usually days of going on steroid therapy and suspending drugs, they will start to feel better. And so you want to confirm that that's the case. And then monitoring them on a week to 2 week basis while they're on their course of steroids is important. One, to ensure that they're continuing to improve, and two, to move your steroid taper along, right? So that you're not leaving them on these lengthy steroid, high dose steroid doses for longer than they need to be. And so that's talking to them about symptoms, monitoring resting and ambulatory oxygen saturation. And typically I'm not re-imaging them until I am close to the end of the taper or at the end of the taper myself. In part because I haven't found plain chest radiographs to be that helpful in these circumstances, but mainly because of the radiographic lag. You know, I really don't expect them to start looking dramatically better until they're weeks into their steroid treatment. Certainly, if they are doing better and then start doing worse again, I'll absolutely re-image them and more comprehensively reevaluate whether I have the right diagnosis in the first place. But that's typically my pattern. If someone has pre-existing lung disease or has never had PFTs before, I my own practice is that I don't obtain pulmonary function tests on informal PFTs until we're through the acute storm, because I don't know that that data is going to change what I think at the time, and it's not going to be an accurate representation of where their lung function lands at the end of the day. For those that have lower grade disease, so grade 1, and are going to be re-challenged at the end of their, in the resolution of their initial reaction, so whether that's with steroids or without, I want to know what their lung function and their imaging is like at the end of treatment, particularly if they're going to go on to get re-challenged. And then I do follow them pretty closely. Like, I'm seeing them back within a couple of weeks of them restarting on drug. But I also know that my oncology partners are watching them like a hawk as well. But I'm not doing repeat imaging necessarily any earlier than 4 to 6 weeks after re-challenge, unless they develop symptoms again.
And since we're pulmonologists, like, is there a role for like bronchoscopy in these patients? Is it just if things aren't, because you had mentioned like most patients in your experience do pretty well when you start them on steroids, you save it for if they're not doing so well, or what's the role of bronchoscopy in these patients?
My answer is applicable to like really all drug reactions that I encounter, which is that, you know, for the patient who's neutropenic, which these aren't, you know, I always have bronchoscopy for those patients because the incidence of infection is so high. Otherwise, I proceed directly to bronchoscopy for patients on targeted therapies. If there is ambiguity about the diagnosis, certainly. So if there's any question, and I think this will come up more with lung cancer patients, whether there's disease progression or because they have underlying lung disease, is it actually acute or chronic infection that hasn't been picked up by a non-invasive workup, you know, with sputum culture and viral swab, then there's certainly no harm in doing a bronchoscopy, as long as you aren't delaying initiation of steroid therapy over much, right? Like, you want to go ahead, obtain your diagnostics, and embark on treatment and not drag your feet. I think that where we run into a lot of challenges are on the higher grade reactions, where you do actually want that data. You want to be certain about your diagnosis, but they are often so fragile, you know, hovering on high flow and trying to stave off intubation, that your window for obtaining even just a BAL is pretty narrow. And so that decision has to be taken into account, the risk versus the benefit. For patients who appear to have steroid refractory disease, then when at all possible, I obtain repeat or initial bronchoscopy before introducing secondary immunosuppression, just because we know that what these patients tend to expire from is infection, you know, whether it's secondary or primary cause of their respiratory decompensation. But again, you know, it's a question of whether you have a clinical scenario where it's safe to do so. If they're already intubated, then, you know, typically you can. But if they're not yet intubated, it can be a really challenging decision to make at that point.
And just a follow-up question for Dr. Possick also. How long do you tend to continue your initial dose of steroids that you may recommend 0.5 to 1 mg per kg per day? How long do you continue that dose for before you start to taper?
I think we all know that there's no real right answer to how to manage steroids in these patients. I don't decline their dose, all things being equal, until they start demonstrating clinical improvement, right? So I really want their symptoms to be improving. I tend to find that takes the better part of a week usually. And so then at that point, if I'm planning to taper them over 4 to 6 weeks, depending on what dose they've started at, it tends to march out in a fairly mathematically manageable fashion. I think there are caveats to that. You know, patients who tolerate high dose steroids really poorly either because of unmanageable hyperglycemia or, other steroid side effects. You sometimes have to balance those factors in and how you tend to manage it. But because so much of this does tend to follow an OP type pattern, if you taper them too quickly, you often lose ground. And you can inadvertently end up on steroids much longer than you might have otherwise, I think, if you had not upfront treated them more as aggressively as possible with higher dose steroids. And that's my experience and opinion, but obviously that doesn't bear out in the literature necessarily.
One question for Dr. Gatti-Mays. If it's a grade 1 pneumonitis for which you're considering to perhaps restart therapy with ADC, is there a particular steroid dose at which you would be comfortable restarting, or do you want the patient to be completely off?
So, I think it ideally they would be probably completely off steroids. I know in the immune checkpoint inhibitor criteria, typically we say under 10 or at the most 20 milligrams of prednisone per day. Again, this is a different mechanism. So I think we don't necessarily need to be worried about, are we at the physiological steroid dose? In the patients that we're restarting, I think ideally I would like them off steroids and pretty much back to baseline. I did want to, I agree exactly with what Dr. Possick had said too, is, in my experience, I feel like the patients, they can respond quickly to steroids, but if you taper too quickly, I think that we tend to have a little bit more of a rebound with this, and it probably has to do with the prolonged half-life of these drugs. If it's truly due to the payload, kind of like a mechanical injury to the lung or chemical injury to the lung. I think because these agents hang around a little bit longer, to me, that's why it's always made sense that we probably need a little bit longer taper. And so, especially with those lower grade pneumonitis, it may take a little bit longer to get them off the steroids and before you really feel comfortable resuming.
Yeah. Okay, also in clinical practice, how frequently have you seen ADC pneumonitis to be steroid resistant or steroid refractory? And what are some of the non-steroid options that you commonly use?
So, I have to say, and I actually don't really think I've seen any cases personally in my patients that have been steroid refractory. I work pretty closely with Kevin, and I don't know if he has any other that are potentially on his mind, but I don't think that I've really seen any that are truly steroid refractory. I don't really think we have great guidance, even in like the package inserts and in the clinical trials, about the non-steroid treatment options. Again, since this isn't like immune checkpoint inhibitors, I don't know how much really like mycophenolate, or IVIG, or infliximab potentially might help. I think, there's obviously people are trying that because I don't think we have great data at this point to show really what to use. But I think from the mechanism perspective, I think, typically just withdrawing the agent using the high dose steroids, the majority of cases that I've seen have resolved. I've not re-challenged those patients. But, I think just with doing that, they've, it takes a little bit of time, but are able to eventually respond to the steroids.
So just to follow that up, and I think this has been kind of covered in some of the answers to the other questions, but just more directly, so what is the role for reintroduction of these agents after pneumonitis? How would you go about it as a clinician?
Oncologist. I guess that's maybe I'll start with that one. I think with stage 1 or with asymptomatic grade 1 just found on imaging, I think I would feel comfortable reintroducing ADCs. Anything more than that, I think it really definitely, grade 3, I would not reintroduce. I think with grade 2, it kind of depends on really how symptomatic they were. But I think even with that, we don't really have great data in terms of if we can reintroduce safely. a lot of times in that gray area for patients, it's a discussion with the patients about their goals, about their remaining treatment options. If they have a lot of options still left, and this is not the only agent that they have available to them, we'll cycle to another agent. But if this is it and they've had a great response, I think it is a big discussion about the pros and cons. And if you did reintroduce, making sure that we follow, have you guys in pulmonary follow very closely as well.
And just a follow-up question for Dr. Possick. As you said, these patients tend to respond very fast to steroids. And you said, within 1 week of high-dose steroids, they start clinically improving. Now, say if a patient is responding, a little bit slower, is there a certain duration at which you would say that, well, they're not responding to steroids, maybe they are in fact resistant, and then you would consider another immunosuppressant?
I think, there's a lot of nuance there. I think that if I've had someone held at the same initial dose of steroids for, say, 2 weeks, and they've made some modest improvements, maybe the cough is gone, but they're still short of breath, or or they've improved partially, but symptoms are still there, and radiographically there's only been partial improvement. Again, particularly if they have an organizing pneumonia pattern, I would probably start to entertain introduction of a sparing agent sooner rather than later, only because you anticipate that you will need something else on board, maybe in those cases. And in the interest of ultimately being able to get someone off of high-dose steroids, it may behoove you to at least have that discussion with the patient and contemplate it. To be perfectly honest, I haven't had to do that other than maybe 1 or 2 times. I have had people that I've gotten down to the end of a taper and they can't seem to liberate from that last 5 or 10 milligrams. And a lot of patients will be resistant to the idea of going on a sparing agent rather than just continuing with that kind of a dose. It's been more of an issue with ICIs, I think, where you continue to see this persistent immunomodulatory effect rather than these cases. I think what I've seen with ADCs is the reactions are really prevalent. A lot of them are really manageable. When it's fulminant, it's really terrible and very hard to manage, but that's thankfully not that common.
Yeah, out of the patients I've seen, at least, there have been like 2 that were like pretty convinced. I think steroid refractory pneumonitis is controversial because you never know if you're just like missing an infection, like you had brought up. We did have like 2 pretty convincing cases that died in our intensive care unit. And they had like bronchoscopies because they were intubated, and infectious stuff was all negative after we gave them a lot of antibiotics and such. But yeah, we tried like a couple things and neither of them really worked. So I'm curious if whether it's misdiagnosis, is this actually a thing? It's pretty rare. It'll probably take some time to like really see how things go and if this comes up more or not.
Yeah, I think maybe the thing that we do collectively not so well is we maybe miss our window. That's what I've wondered about in our patients who have expired in the ICU with refractory reactions from a variety of agents, is that maybe the time for them to have responded to IVIG or to infliximab was a few days before we got there, and that's why I think that the updates to the guidance around ICIs is so important, where they're really urging people to reevaluate in 48 to 72 hours, which can be really hard to tell, right? Like, is your patient making any progress or not at that point? And with this population, we don't know that yet, but we don't have that information yet. And we don't know how best to manage them, which is why the guidance is as vague as it is.
So I think that's all of the questions that we had prepared in advance, but Kevin, are there any in the chat that people have submitted?
No questions in the chat. I think we have
Okay.
5 minutes. Yeah, if you guys have any, feel free to throw them in there. But if not, thanks for all our experts for giving up an hour of their day, and thank you guys all for attending.
Yeah, this was wonderful. Thank you to everyone who spoke. It was very illuminating about this new and very exciting therapy from every perspective.
Thank you for having us.
Thank you for giving us your time.
So if there are no submitted questions, we can wrap up for the day. Thank you, everyone, and stay
Thank you.
safe in the snow if anyone's experiencing it like we are here in the Northeast.